I'm going to be presenting an orthopedic case summary. This case involved a 41-year-old active male who presented to primary care with a severe right ankle injury sustained while playing basketball with his son. The injury occurred when he landed on his son's foot, causing a forceful inversion injury. He immediately heard and felt a pop, followed by rapid swelling, severe pain, and complete inability to bear weight. Over the following 2 weeks, despite conservative treatment with rest, ice, compression, and elevation, ibuprofen, and topical Voltaren gel, immobilization, and activity modification, his symptoms continued to worsen. The swelling progressed from the ankle into the mid-calf and distally into the foot. Extensive swelling all the way to the toes. Extensive ecchymosis developed from the shin down to the toes, and he reported numbness, burning pain, calf tenderness, erythema, and pitting edema. Because this patient remained unable to bear weight and was not improving with conservative treatment, this became much more than a routine sprained ankle. Challenges that I encountered: although I had evaluated ankle sprains previously, this was one of the most severe injuries I had encountered during clinical training. It challenged my musculoskeletal assessment skills and highlighted the importance of knowing when a patient requires a specialty evaluation. One of my greatest challenges was determining which physical exam maneuvers were most important to perform in a patient with this degree of swelling. I learned the importance of performing ligament-specific testing, including an anterior drawer test and talar tilt test to evaluate ankle stability, as well as assessing the syndesmosis with examination of the anterior-inferior tibiofibular ligament. I also learned how swelling can significantly limit the reliability of some physical exam findings, making follow-up examinations and advanced imaging necessary. Another challenge was determining the extent of the imaging required. Initially, I understood the need for the ankle X-rays to evaluate for fracture using the Ottawa ankle rules. However, because of the severity of the swelling and pain extending beyond the ankle, additional imaging of the foot and the tibia fibula was also necessary to rule out associated fractures, including like a distal fibular fracture, metatarsal fractures, any occult fractures not apparent on initial examination. As the patient's symptoms failed to improve over 2 weeks despite appropriate conservative management, it became evident that MRI was definitely indicated. MRI was necessary to evaluate for complete rupture of the anterior talofibular ligament, the calcaneal fibular ligament, syndesmotic injury, a tendon injury, and other soft tissue damages that could not be identified on plain x-rays. These findings also supported referral to an orthopedic foot and ankle specialist for definitive management. An additional concern that I had not previously encountered in an ankle sprain was the need to evaluate for deep vein thrombosis. Because this patient demonstrated significant swelling extending into the calf, pitting edema, erythema, calf pain, skin was warm to the touch, prolonged immobilization, and with use of hormone replacement therapy, his risk for a venous thromboembolism had increased. This required consideration of a venous ultrasound to exclude a DVT before attributing all symptoms solely to just the orthopedic injury. Pharmacological learning points. This case expanded my understanding of medications used in managing severe orthopedic injuries. Prior to this experience, I was comfortable with recommending non-steroid anti-inflammatory drugs, acetaminophen for pain control. However, I learned that treatment may require a broader individualized approach depending on the patient's symptoms. Because this patient was experiencing this burning pain and numbness, I learned when medications such as like gabapentin, Lyrica may be considered for neuropathic pain if symptoms persist. I also gained knowledge regarding like selective use of muscle relaxants such as cyclobenzaprine and methocarbamol for secondary muscle spasms that can occur following the musculoskeletal injury. Another important learning opportunity included DVT prophylaxis. Although not every ankle sprain requires an anticoagulation, patients with prolonged immobilization and additional risk factors, including hormone replacement therapy, may require DVT risk assessment. In selected patients managed non-operatively, orthopedic providers may recommend an aspirin for DVT prophylaxis. This decision should be individualized based on bleeding risk and current orthopedic recommendations rather than routinely initiated in primary care, although it can be done so. Some other considerations: if the patient is a smoker, obesity, could consider like Eliquis. Evidence-based resources. This experience reinforced my FNP that FNPs are not expected to know every aspect of orthopedic medicine. Instead, advanced practice requires knowing where to obtain reliable evidence-based information. Some resources include UpToDate, American Academy of Orthopedic Surgeons, OrthoBullets, American Academy of Family Physicians. This case demonstrated that advanced practice nursing is not about having every answer immediately, but about using advanced clinical reasoning, recognizing limitations, consulting evidence-based resources, and collaborating with specialists to provide the highest quality of care. I learned that several severe ankle injuries require far more than simply diagnosing a sprain. They require a comprehensive neurovascular exam, careful assessment of fractures, syndesmotic injuries, tendon injuries, compartment syndrome, and venous thromboembolism. Equally important is recognizing when conservative management is failing and when referral to an orthopedic specialist and advanced imaging are necessary. This evidence strengthened my musculoskeletal assessment skills and reinforced the importance of lifelong learning, evidence-based practice, and interprofessional collaboration. As a future family nurse practitioner, these lessons will improve my confidence in managing orthopedic injuries while ensuring that patients receive timely specialty care when indicated.